First off, I'd like to thank Dr. Phillips for inviting me to this 30th Annual Breast Cancer Awareness Symposium. I'm honored to be here and to get to talk about ductal carcinoma in situ and the current controversies. There are about 63,000 new cases of ductal carcinoma in situ a year now. And that's added on top of 268,000 invasive breast cancers. But this is a bigger and bigger proportion of all the breast cancers we diagnose for reasons we'll talk about. The death rate in 2019 was about 42,000 patients in the country, second leading cause of cancer death. And as most of you know, about 1 in 8 women will develop an invasive breast cancer sometime in her life. DCIS is a very special situation. I have this conversation a lot with patients in the office, in fact, every day. DCIS is called stage 0 breast cancer. And I think that's really reassuring. Stage 0 means that there are cancer cells present, but they're confined to the milk ducts where they started. They have not broken through the lining of those ducts. They don't have access to lymphatics or blood vessels, and so they really cannot spread. In fact, women with DCIS have the same survival as women with no breast cancer. The reason that the incidence of ductal carcinoma in situ has gone up so dramatically in the last 30 years or so, in about the mid-1980s, we really started using mammography regularly and more after that. And mammography can find ductal carcinoma in situ because it shows up as little fine flecks, little white spots on the mammogram. This is way before you can feel anything abnormal in the breast. So up until we had mammography, most women found breast cancer because a lump formed in the breast. But once mammography was available, we could find these little ductal carcinoma in situ, stage 0, before there was any invasion. But this also led to a period where we were finding a whole lot more cancer per year if we included this stage 0 DCIS than we ever found before, because there were cases out there that we wouldn't have found for years after that. Currently, the treatment guidelines that are put out by the NCCN, the National Comprehensive Cancer Network, include a number of options. And so that's part of why we're talking today about what controversies exist around DCIS. The most common recommendation is for lumpectomy, removal of the tumor with a rim of normal tissue, a clear margin, without any lymph node surgery, but with whole breast radiation treatment. But other options include mastectomy, with or without lymph node removal, or lumpectomy with no lymph node removal and partial breast radiation, or lumpectomy without lymph node removal without radiation. And we'll talk about why those options all exist. The current treatment options really amount to breast conservation treatment, which is recommended. It's the recommended treatment, including lumpectomy with clear margins, plus breast radiation, which can be whole or partial breast radiation. And we use plastic surgery techniques as needed to give us a good cosmetic result. Another option is mastectomy, usually with reconstruction, although there are many women choosing a go flat option now. We have to be careful to make sure we're asking women what they prefer and showing them some of the options that they have. We choose mastectomy, or we recommend it, if clear margins cannot be obtained, or if the patient prefers it, or if the patient has a very high risk of another breast cancer, say she's young and has a BRCA mutation. Lumpectomy alone without radiation is more and more a recommendation that we use in our practice for reasons we'll talk about. And then there are clinical trials now exploring no surgery at all, no surgical removal after biopsy, just with hormone blocking medicine or just with surveillance. Now, those are the local treatments, removal of the tumor and radiation treatment, but there's a systemic treatment that we often recommend, hormonal therapy. Most of these DCIS lesions have hormone receptors, estrogen receptors, and in taking a hormonal therapy, a hormone blocker, can reduce the risk of recurrence of the original lesion, but it also reduces the risk of new lesions either in that breast or in the other breast. About half the women, and maybe a little less, choose this option in addition to the local treatment they get. The three controversies we'll talk the most about are the margin size that's needed, If you require a larger and larger margin size, then you end up recommending mastectomy more often if you can't get that larger margin. We certainly don't want to do that if we don't have to. The biggest controversy, and we'll spend the most time on this, is lumpectomy with radiation versus no radiation, and in particular, how do we identify those patients? And finally, biopsy without surgery. This is in the stage of clinical trials. This patient would be a great example because you could get correct answers from many different surgeons, experts around the country, and it might be any of these choices. You have a 54-year-old woman who's postmenopausal. She's got an 8 millimeter favorable grade 2 estrogen receptor positive DCIS, and she's had a lumpectomy. She's got a negative margin, a clear margin, but it's less than 1 millimeter in thickness. And so the choices might be re-excision or no re-excision. She might get a recommendation for radiation treatment after her lumpectomy or not. And we might use a genomic test. We might use a biological profile to give us more information about the biology of that particular tumor, because we've learned that just looking at the clinical factors like the patient's age and the size of the tumor, or the pathology factors like the grade of the tumor, isn't as helpful as we have hoped it would be. So the margin that is required for DCIS, the real required margin, is no ink on tumor. When we take this lumpectomy specimen out, the pathologist or the surgeon will put ink on the surface. And if the pathologist looking under the microscope sees cancer cells touching that ink, that's called ink on tumor, that's a positive margin. That means there's tumor at the surface of the lumpectomy, not a clear margin. You have to go back and do more surgery. But recent studies have shown that with DCIS, a 2 millimeter margin is really ideal. Gives a little better local control. So this has led to some controversy because very recently, several of the societies that look at breast cancer, whether it's surgical societies or radiation societies, have given new guidelines that talk about use of a 2 millimeter margin. And they took great care in the publication to make sure this was not a hard and fast rule, but many people just saw the headline. And so the headline was, consider re-excision for any margins less than 2 millimeters. If you only read that headline, you could end up doing a re-excision or a mastectomy in a case where you really don't need that. If you look in the finer print here, you can see it says no ink on tumor rule is maintained. In fact, if you go deeper in that publication, what it says is that negative margins less than 2 millimeters alone are not an indication for mastectomy. Clinical judgment should be used to determine the need for further surgery. And there are a number of factors we'll talk about that impact the risk for recurrence, and those should be considered before re-excision. Now, here is a really surprising and a really important sort of a foundation of what we do and why we do it with DCIS. This is an overview. In fact, it's a combination of the 4 largest randomized trials where patients either had lumpectomy with radiation or lumpectomy with no radiation. And these treatments were randomly assigned. This is sort of the gold standard in medicine to make sure something really helps or it really doesn't help. And I think you'll find this surprising if you haven't seen this data before. In the first place, what they saw when they put all of these studies together and looked at the outcomes was that without radiation, after lumpectomy with a clear margin, but without radiation, about 28% of patients had a local recurrence at 10 years. If they gave radiation, that was cut in half to 13%. So breast conservation surgery plus radiation cut that local recurrence in half. And so that's a dramatic proof that radiation reduces the local recurrence risk. And you'd think, well, okay, maybe that's obviously we should give this to everyone. But if you look at this another way, what you also see is that 70% of patients or so, 72%, did not need radiation. The trick here is figuring out who those people are. Who are these 28% that really needed it? And who are the 72% that did not need radiation? Because we really overtreat most patients if we look at this data in one way only. And even more important, when we looked in the same studies, the same overview, at the breast cancer mortality, radiation made no difference at all, literally zero difference. So the women had the same outcome, whether they had this local recurrence or not, as an overall group. meaning no improvement in survival, which was just too good to improve upon in the first place. It really makes this disease sort of similar to the breast cancers that people have treated for sun damage, and you get that treated and it's done. Looking at this data around the same time and shortly before that overview came out, the NIH did a State of the Science conference on DCIS, and basically the bottom line statement that came out of that conference was that future research has to focus on accurate risk stratification, risk identification methods, including clinical and pathological factors, but also biological factors associated with DCIS, so that we don't overtreat 70% of patients. In fact, the NCCN guidelines also say if the patient and the physician can identify an individual as low risk, then some patients can be treated by excision alone. But how do we detect low risk? Well, we've known for many, many years there are certain factors that are associated with prognosis. Those are age, size of the tumor, grade of the tumor, and margin status. Those factors are definitely associated with better or worse outcomes. They're the clinical pathologic factors that we use. If you want to look at high risk versus low risk DCIS, looking at those factors, high risk would include things like a palpable lesion. That's very unusual. You can occasionally get that. That was what we found before we ever had mammography, but those are more advanced, non-invasive lesions and more dangerous. Also, grade 3, high-grade lesions or tumors that have necrosis, dead cancer cells in them, estrogen receptor negative, and tumor size greater than an inch, greater than 25 millimeters. Young patients also have higher risk, and certainly positive surgical margins increase risk. Close margins that are clear, not so much, but they're still included in that category. Low risk DCIS is detected on mammogram. It's not palpable, doesn't make a mass. It's grade 1 or 2, low grade or intermediate grade, same thing. No necrosis, estrogen hormone receptor positive, tumor size less than an inch, less than 25 millimeters. Patients over age 50 and negative surgical margins equal to or greater than 2 millimeters. So what we would hope is that putting those factors together in an intelligent way could tell us who needs or doesn't need radiation, who benefits or doesn't benefit from radiation. Unfortunately, when that's been done, and this is a large retrospective study from several institutions combined, even when we combine our best estimate of low grade and small size and low risk, we see there's a pretty substantial benefit, reduction in risk with radiation treatment. There is a similar reduction in risk if you have what's considered to be a high-risk lesion. So using clinical pathological factors alone really has not worked. This has been tried in a number of efforts. This one is a prospective randomized trial. And I want you to remember this for a minute. We'll talk about it again, called the RTOG 9804 trial. And it looked for women who had very low risk, mammogram detected tumors, DCIS grade 1 or 2, smaller than an inch, less than 25 millimeters, who had lumpectomy with a negative margin, in fact, a good 3 millimeter negative margin. These were considered good risk patients. And in this study, they were randomized either to observation or to whole breast radiation treatment. But what we saw in that study, especially over time, was that radiation had a dramatic impact, reducing the risk of local recurrence, especially as you got out to about 10 years and certainly at 12 to 15 years. So these clinical pathologic factors, even though they are associated with outcomes, kind of let us down if we're looking for which patients really don't benefit or don't need radiation treatment. So what can we do? Well, some stronger efforts have been made looking at clinical pathologic factors with computerized analysis. So this is a nomogram from the Memorial Sloan Kettering Cancer Center, where you put in every detail you can think of that really relates to outcomes, and the computer tells you what's the patient's risk, what the benefit of radiation might be, and what the impact of hormone blocking medicine might be. This worked very well at Memorial Sloan Kettering. Unfortunately, it hasn't been reproducible in other institutions on a reliable basis. The same thing really happened with the first nomogram that we used many years ago, and this was developed by Mel Silverstein at the Van Nuys Breast Center. And basically, it scored size, the clinical pathologic factors, including pathologic classification, grade, margin width, age of the patient. And a high score was really those higher risk features, and a low score included those lower risk features. And you can see on the left, the low scores had no difference whether they got radiation or not. On the right, you can see the high scores had a big difference, a big benefit with radiation treatment. Unfortunately, here again, this outcome, this correlation with outcomes, couldn't be reproduced well at other institutions. So right about the time that overview came out, looking at those 4 randomized trials put together, Henry Curer, who's an expert at the MD Anderson Cancer Center and a friend, published an editorial in the Lancet Oncology sort of talking about, what does this mean? What do these findings mean? And basically what they mean, according to Dr. Curer, was that we're overtreating many cases of small mammographically detected DCIS. Our focus should be on accurate molecular identification of patients with DCIS who can forego therapy safely because their risk is so low. Okay, so that's where the biology comes in. That's where bioassays, including this one, which is a genomic assay called the Oncotype DCIS score, comes in. Oncotype originally was developed around invasive cancer and could really tell you whether you had a benefit from chemotherapy or not. And so that company used that expertise to develop the Oncotype DCIS score to identify similar factors in DCIS lesions. And the bottom line is there was a very good, validated correlation with outcomes, with risk for patients who had a particular score, a particular genomic profile, plus their clinical factors, their age and tumor size. So you can see on the left here, this patient has a pretty high score. And when that's put together with her age and her tumor size, you can see she has a 23% overall of a recurrence at 10 years, and she's got an 11% risk of an invasive recurrence. On the other hand, a lower score, 27, in this patient who's older on the right, over 50, and had a core biopsy or a size not provided. She has a pretty low risk, a very low risk of recurrence, 9% for any recurrence and 6% for an invasive recurrence. And it's debatable how much better you can make that with radiation. You might make 6% go down to 3%, but is that worth all the treatment that she's going to get? And this is not a foregone conclusion. The doctor doesn't just say, okay, no radiation for you. This information informs the discussion that you can have with the patient. And one patient will choose something in this situation. Another patient might choose something else. And she's well informed. We're going to respect her preferences. The good news is that in this overall meta-analysis of 2 trials used to validate this assay, about 70% of patients that had this favorable profile did have a risk less than 10%. And that's useful information for that discussion. The next profile that came along is called DecisionRT. It's another biological profile looking at the proteins that are expressed in the cells and on the cells, combined with also clinical factors, the age of the patient, the lesion extent, and the margin status. And it did something that we couldn't do with clinical factors alone, clinical pathologic factors alone. It really appears to identify a group of patients who don't have much change with radiation. They start with a low risk and they stay with a low risk, but that doesn't change much if they get radiation. So this is getting close to identifying a group of patients who have a low risk, who really don't have much change with radiation. On the other hand, the patients who are identified by this profile as elevated or high risk have a dramatically bigger benefit with radiation than we're used to seeing, 28% here going down to 6%. Now, this was a retrospective analysis. So the next analysis with this particular assay was done with one of the studies, one of the randomized trials in that overview. This was called the SWE DCIS study from Sweden. So when that tissue, which was available from that study, was put through this assay and the results were correlated with outcomes for the patients, what you could see, if you're talking about invasive recurrence, and that's the kind of recurrence we're concerned about most, there was really no significant difference with radiation in the low-risk group, about a 1% difference that was not statistically significant. But again, in the high risk group, there was a dramatically bigger reduction in risk than we're used to seeing with radiation, maybe about a 75% reduction, a 9% absolute reduction. And then if they went back, taking this same assay and looking at the RTOG 9804 study, and that was really interesting. You'll remember the 9804 study looked for good risk DCIS patients, but still they had a very big benefit, a pretty dramatic benefit with radiation. So using those clinical pathologic factors, we really couldn't separate out which patients benefited and which didn't. But when those patients in that good risk group were put through this particular assay, we could find a group of patients in there. All were supposed to be low risk based on clinical and pathologic factors, but we could find a group that were biologically low risk. And again, you can see here, they have very little change if they're in that low risk group with radiation, maybe 1%. And if they had a high risk based on that assay, even though all were in this low risk group, they had a much bigger reduction with radiation treatment. This assay generates a report that you can show the patient. And on the left here, you can see a patient with a low score who has a low risk of recurrence with no radiation and about the same with radiation. So here you're inclined not to recommend radiation treatment with the caveats that no test is perfect and we're not always correct. On the right side, you can see this patient has a score that's much higher, has a much higher risk without radiation and a much lower risk with radiation treatment. As an example, you can see a patient who has a very low clinical pathologic risk, small tumor size, low grade, solid tumor, no necrosis, screen detected, meaning detected by mammogram. She did not want radiation treatment. But when she saw her score, which was a high score and predicted a risk of recurrence around 22%, considering the tumor size, considering her age, et cetera, with a reduction to about 10% with radiation, she did decide to have radiation treatment. A similar patient, also with a low clinical pathologic risk, who did not want radiation, mainly because she was concerned about that causing a bad cosmetic outcome when she was hoping for a better cosmetic outcome, gets some reassuring information with this lower score. And with this information, decides to decline the radiation treatment. And I think her doctor agreed with her. When we looked at a large group of patients over time and how much impact this analysis of the tumor tissue had on decision-making, you can see a fair number of patients who initially got a recommendation for RT, for radiation, in the blue, converted to no recommendation for radiation in the gray. And likewise, patients who initially started with a recommendation that they didn't need radiation, a substantial number of those patients ended up with a recommendation based on that biologic information. The last thing we'll talk about is something called overdiagnosis. Overdiagnosis is identified by the National Cancer Institute and in general as a situation where any treatment is overtreatment. These are cancers that would otherwise have never been discovered, would never have caused symptoms or death in a woman's lifetime. You can imagine if you found a small DCIS in a woman who's 80 years old, for instance, and it was going to do some harm to her over the next 30 years, it's probably not going to have any impact in her lifetime. So this is listed as a possible harm from screening. We're not used to really thinking about possible harms other than the stress and the aggravation that you have to go through to make sure you're okay, or whether you need a biopsy or whether you need cancer treatment. The National Institute of Health estimates that the size of this effect of overdiagnosis could be as high as 50%, but probably at least around 1 in 5 patients get a diagnosis of a DCIS that may never have caused them any trouble. This was really publicized a lot back in 2015, and there were a number of newspaper articles, news articles about women who sort of regretted their treatment or at least doubted whether they needed it. These came out in all of the major publications. One of the leaders of one of the current trials, Shelley Wang, has pointed out that not all DCIS progresses to invasive breast cancer, and this is the reason for these studies. Presently, outside of a clinical trial, we don't recommend this approach. We recommend removing the lesion with a clear margin and then an informed discussion about whether you need radiation treatment or not, and whether you want to take hormone blocking medicine or not. Still, if you look at the reported treatment patterns in the US over the years 2007 to 2011, and let's just limit our attention to the ductal carcinoma in situ group on the left, because lobular carcinoma in situ is now not even classified as cancer anymore. And that may be something that happens with DCIS once we get smarter about the biology. But the tiny little gray boxes on the left are patients who did not get any surgery. They just got a diagnosis and were followed up. The darker gray is patients who got a lumpectomy, surgical removal. The light blue, patients who had mastectomies, and the purple, patients who had both sides mastectomies. You can see what you might even guess. Patients who were younger chose mastectomy or both sides mastectomy more often because they didn't want 60 years of mammograms and maybe abnormalities and biopsies. And it was also puzzling, why would they get that disease so young? But you can see this is already going on to some extent based on patient selection. And that's what we see here. This is a very, very large US database of patients treated in the US. And what we see here is that if you look at the total patient cohort, if you look at patients who did and did not have surgery, there was a difference. There was a 98% years of follow-up with breast cancer specific survival if they had surgery, but it went down to 93% at 10 years breast cancer specific survival if they did not have surgery. On the other hand, if you just looked at the patients in that big cohort that had low-grade DCIS, there was zero difference in outcomes. Now, this is really due to patient selection. These are not randomized patients. These are patients that were selected by the physician, and who knows, they may have had other serious comorbid conditions like heart problems. But in any case, this does suggest that we ought to be able to find this group of patients who may not need even surgical removal of that tumor. There are five trials right now, 3 of them randomized, and 4 of them you see right here. The US trial is called the COMET trial. That's the trial that is, one of the leaders is Dr. Shelley Wang that we mentioned a moment ago. And that randomizes patients to get surgery or observation. In either group, the patients may have endocrine treatment for 5 years. Other trials are international trials, all looking at this question, none with answers as of yet. So management after lumpectomy for breast cancer patients, we know for a fact that radiation reduces risk of recurrence in the breast for clinical pathologic high risk and clinical pathologic low risk DCIS. It does appear that biomarker profiles are giving us a much better estimate of risk of recurrence and also radiation benefit for those patients, and that helps inform that decision making. Hormone blocking medicine can really reduce recurrence in patients who choose to take it, and also reduce new cancers in either breast. Bottom line here is that treatment for ductal carcinoma in situ after lumpectomy should reflect the patient's values. The informed patient should have a shared decision-making process with her doctor. Thank you.